episode of ASSI, the Association of Spine Surgeons of India's interactive webinar on osteoporosis and osteoporotic spine fractures. We have the stellar faculty as experienced from youngsters to the very senior people, and the cumulative experience in this group is around 150 years of spine experience, and I'm sure we will have something which is very interactive, interesting, and learning for everyone, including us. Without taking much time, I would like to invite my colleague and my co-convener, Dr. Nene, to say a few words before we start. And Nrupam will be the first presenter. Dr. Nene.
So ASSI has always been up to date with what's going on, and osteoporotic vertebral fractures is hot right now in our practice. I think all of us are suffering from the problem of osteoporosis. It's a surgeon's ego destroyer. So we chose this topic today, and Dr. Hadgaonkar has worked nicely through a mix of cases as well as real life scenarios and then some theory. But we're going to begin with one of our young dynamic ASSI members, Dr. Nrupam Mehta. She's going to talk to us about the history and a very generic understanding of radiology. Nrupam, it's over to you.
Yes. Good evening, sir. I'll just share my screen.
Yes, we can see this, Nrupam.
Yes, sir.
Caller.
Good evening, everyone. Thank you for giving me this opportunity to ASSI and Dr. Shailesh and Dr. Nene. So we'll start with basically, this is a case that came in the OPD this morning. Sorry. Yeah, this is a case that came to OPD this morning. It's about a 67-year-old female who had a history of fall 1 week ago, who had mid-back pain, but her neurology was intact. So a lot of questions come to mind that what can we do? Can we conserve? Can we brace this? Can we, offer the patient some bed rest, operate? Will we go, ahead with a vertebroplasty or kyphoplasty, V-plasty with stabilization, just stabilization? And then another question, is this correlating? Is this fall, last week relevant to us right now? Do we know if this is old or this is new? And is this going to go towards non-union? So my topic for today is, basically showing you all the historical perspective, classification and imaging. I'm Dr. Nrupam Mehta, and I'm working as a spine fellow currently in Bombay. So coming back to the same case, again, we don't know what to do. So in the olden times, just before, probably pre-2000s, we would have offered this patient bed rest for almost, 3 months, go lie down, given analgesia, not intervened. Or, at the most given a brace, which these are the recent most braces that you see. But now just going into the historical perspective, in 1940, actually people started talking about osteoporosis, women, estrogen loss, etc. Then a big classification that came up was the Genan classification, which became the global standard. I will elaborate on that in the coming slides. And then in the late 1990s, vertebroplasty, kyphoplasty, these concepts started coming up. In the early 2000s,
Your slides are not moving.
The roads.
Sorry. So it's moved. Now?
We are seeing a slide with the brace. Your slide number 5.
Yes, sir.
But can you enlarge the screen?
Go to slide show, please.
Yes, sir. Sorry. Can you all see now?
You're not sharing anymore.
Okay.
Also, in the meantime, I would like to welcome Dr. Vishal Kundani, our very dear friend, but very great academician from Mumbai, will be co-moderating with us today, and he is willingly planned something different for panel discussions and debates. So Vishal, we would like your presence all time today in this webinar.
Nrupam, please share your
Yes, sir.
screen.
Yes, sir.
Yeah, now you're sharing it. Now go on slideshow. There, on top. You can see slideshow on top, not that.
Yeah, okay.
Slideshow on top,
Yeah.
not that. Okay,
Is
now
it?
move forward to
Yeah,
your current slide.
yeah.
Not moving.
Is it going
Okay.
ahead?
Yeah, it's going
Yeah,
forward.
yeah. Sorry. Okay, so basically that was the historical perspective. Now we'll go to the Gannon's classification. It only spoke about the morphology of the fractures. It basically spoke about patient is presenting like a classic OVCF, instability pain, lot of old, fragile, but nothing on the X-ray. It could be a possible grade 0 which has not been picked up by the X-ray. Then there's a grade 1 where there is anterior, middle or posterior loss of height of approximately 20 to 25%. Then there's a grade 2, which is approximately 26 to 40% of anterior, middle, and posterior. And there's a grade 3, which is approximately above 40%. So what are the drawbacks? Basically, this classification was not showing us if the fracture is stable, unstable. It was not accounting for the neurology of the patient, and it was definitely not giving us answers whether we should go ahead, we should conserve, or we should surgically intervene. So then came another classification which was introduced in 2018. It basically was the AO spine classification, which was put forward by the German group. They divided the OVCFs into 5 grades. So the first one basically spoke about no deformation; it was just bony edema on MRI, and typically not visible on X-ray. It was only found on MRI. Type 2 was deformation was there on one end plate with or without only minor posterior wall involvement, and it was less than 1/5 of the involvement. The third one was basically more than 1/5 of the involvement, and the fourth one was a deformation of both end plates with or without posterior wall involvement. There was a definite loss of vertebral frame structure, vertebral body collapse, and the fifth one was basically talking about posterior tension band failure. And it also took into account the neurology of this patient as well as the pain factor of the patient. So this helped us guide if we should operate or conserve. As you can see, there's a whole scoring system here and an algorithm, and points were given accordingly. And if it fell between 0 to 5, you decide to conserve. It was if it was around 6 points, it was the surgeon's decision whether he wants to operate or try a conservative strategy. And if it was above 6 points, then we definitely surgically intervene. Uh, then, now when this patient with OVCFs walks into OPD, what are we really afraid of? Before giving our plan down, that what if this goes into non-union later? You've counseled the patient that no, we are going to conserve this. We'll try. We'll keep doing follow-ups. Is he going to have a kyphotic deformity after 3 months? Is he going to show up saying that I've stooped in my structure and this is not what I had anticipated. This is not what you had counseled. And are there any clues to pick up increased probability of it going into non-union? So over the years, a lot of studies have been done where these vertebral fractures could go into non-union. What could be the potential predictors? There's a very good paper by a Japanese group where they just analyzed MRIs of OVCF and they realized that risk factors when when the MRI showed low intensity T1 and low intensity T2 at the end of 12 weeks, it was generally a predictor of going into non-union. Also, greater anterior wedge vertebral body compression was also known to be a high risk predictor. The next was a paper done by my mentor, Dr. Nene. Basically, it was a study of almost 64 to 65 patients where they studied OVCFs and realized that which one was a predictor for higher kyphotic tendency. So TL junction was definitely one, and superior end plate was also contributing significantly for going into kyphosis. So now coming into the radiology part of this. you have the X-ray in front of you. What are you anticipating? What are you supposed to look at? And what is that, quick checklist that you should go through? You should, first of all, isolate that is there an OVCF. Check for vertebral height collapse, end plate, which end plate is affected. Postural wall integrity becomes a little tough. Sometimes you may not appreciate it. Sometimes intervertebral cleft, basically in the vertebra you will see some blank dark spaces, is known as the intravertebral cleft or the vacuum sign. If patient is following up or come to you for the first time after a long history of fall, there may be segmental kyphosis, there may be lysis or even translation. You can check for dynamic instability or potential for healing or follow up with x-rays by making the patient supine or sitting and taking both and checking for vertebral collapse. And also, you should look out that every fracture doesn't come or present as an OVCF. It could be, most of the time, it's an OVCF, but it could also be a pathological fracture in terms of cancer, etc. So these are just some x-rays on, and I'm just elaborating on something. There's loss of vertebral height. There is kyphosis here in the next x-ray, the second x-ray. Uh, Down in the first one, you'll see some superior end plate, and the next one has inferior end plate as well as a little bit of superior, and the last one has a biconcave type of vertebral fracture where the superior and inferior end plate is affected. These are the dynamic instability x-rays that I was talking about. As you can see in the supine x-ray, the vertebral height is much more than the standing x-ray when the patient stands and there's loading on the spine. So this really helps to check for instability, and it must be done as soon as you know there's an OVCF in a patient. At every around 6 to 8 weeks, you must get the patient to do these x-rays and follow up with you in OPD, is something that we standardly follow. What is the role of MRI now? The role of MRI is when the patient is usually not getting better. Second, they are suspecting that this is probably going to non-union based, maybe on the x-rays, or the instability has remained for a prolonged period of time, and or the patient is presenting with neurology. It also helps to show that patient has a multiple, very aged, old or new fracture. Is the clinical radiological connection actually making sense? You can check for marrow edema, you can check for OVCF mimickers, as I was saying earlier. You can check for Kummel's, cord compression. Also in post-procedure assessment, sometimes you've done a vertebroplasty and patient is still not doing well, or comes up with severe acute pain even after the V-plasty. MRI usually gives you a hint as well. So these are some MRI films. The first one, as you can see, is actually not an OVCF. It's a metastatic secondary to a lung carcinoma. So every fracture doesn't become an OVCF. Please look out for everything else. The second, just below it, actually shows a hyper-intense D12 fracture, which was not hyper-intense D12 fracture compared to an L2, which is an old fracture. It's not lighting up on the STER image. And the other images are showing instability between intravertebral and intervertebral. So the below images are all intervertebral and the above images are all intravertebral. And now next, what is the role of CT in OVCF? It definitely, if you're going ahead for a surgical, management, it assesses the posterior wall integrity. It also shows you retropulsion communication if possible. It also picks up intravertebral vacuum cleft sign, screens for malignancy as all, and earlier or even now actually the DEXA is something we do rampantly because of radiation, etc., and its availability. But people used to also assess osteoporosis based on the Hounsfield units. It was used as a predictor of osteoporosis, general osteoporosis, and it also helps with surgical planning. So there's a very interesting paper that I found. I just put it here where they were talking about mimickers of OVCF. One of them was multiple myeloma. And they also spoke generally about multiple insufficiency fractures in a patient. What is the role of bone scan, PET scan? Usually it's not your go-to, it's not your first line, it's usually the second line. Only when the MRI is conjugated, patients who've undergone pacemaker almost 20-25 years back, you don't know or you can't switch it off, that's when you think of even doing this, or you can do it just to check for other sites of uptake other than the spine. Coming next, now you decided to go ahead with a surgical approach. This is a classification again done by Dr. Nene with a couple of his fellows a few years back, and it's been published in the European Spine Journal, where they identified surgical patterns, and based on that, what possible surgeries could be done. So this is something you all should look into. Anyway, this will be explained in the coming forth slide, presentations by other lecturers. So what were my key takeaways? that the Gannon grade severity of collapse and it's only morphological. AO spine osteoporotic classification, although not widely validated, there are a couple of studies and it's not a standard reference. It potentially guides us if you want to operate or not operate. X-ray picks up on the fracture. It's helpful with the follow-ups. And MRI CT confirms neural compression, wall integrity, instability, non-unions, and guides our surgical approach. And these are my references. Thank you.
Nicely covered. You covered a lot of ground there, and I think you covered your history as well as radiology. Do we have any questions or discussion points from the members of the faculty?
Excellent presentation, Nrupama, and just a small point. I prefer to do a supine prone lateral X-ray to see if the vertebral fracture is opening up or not. Because most of the patients who are fragile and they are in the geriatric age group, and you've seen a fracture in your X-ray, a dynamic X-ray of standing and sitting may become a little difficult for them.
Right, sir.
And painful. So most of the time, the radiologist, if you are in tandem with the radiologist, they know when you just write a slip and send to them, they know what to look for. But in these patients, it gives us two. If the fracture opens up, it is an unstable fracture. And as the fracture opens up, you know that on your OT table, whether you're doing a fixation or a cement augmentation, you know how much to fill in. Just one single point. Excellent presentation.
Thanks, sir.
Sir, can I have a question on that?
Yes.
Kali sir, I'm Ranjit.
Yes.
Sir, whenever we
Yeah.
take an acute fracture, we are always going to find some opening up.
Yes.
So how will you base your decision based on that? In an acute setting, if you have to do any fracture to start with, is primarily unstable. Even if you manage to take an X-ray supine.
No, acute fracture, all acute fractures, all acute fractures need not lead to the osteoporotic fracture definition or to be cemented or cement augmented. Most of these fractures which are not unstable, they come to you 2 weeks later with a recurrence of pain, or you feel that they are now unstable because there is a recollapse. These are the subgroup of patients in which if you do a prone lateral and the fracture still opens up, you can counsel them that there is no more point of conservative treatment. I would want to do something more for this fracture.
Great. I think the
How
point
early
is
would you do
well
this
Acute
X-ray?
fractures, we will not.
How early would you do this X-ray?
Come once again.
How early would you
Post
do
2
this
weeks of
X-ray?
the incident of the fall or the
2 weeks.
2 weeks later.
Ranjit, how
Yeah.
soon would you do it?
I will not do before at 5 to 6 weeks.
And you would give medical therapy during that time, isn't it?
Day one.
And how often, Shailesh, do you see a patient whose fracture is opening, closing on the imaging, but is fairly asymptomatic? And then
I
what's your
see. I
strategy
think
there?
quite a lot of patients who are asymptomatic, and I think pain question is also equally important. Pain, instability, and any amount of component which is causing it worsening effect or progressive worsening. These three things are important when you are following up for a conservative patient. And if I see, then only I am more eager or to admit them and give them some injectables or things like that. But normally I prefer 4 to 6 weeks is a standard protocol. But some patients of them are not tolerating that pain where we need to think about something which can be
Dr.
probably.
Das, what is your strategy for asymptomatic unstable fractures?
No, asymptomatic, unstable, I think I will still be very careful when I see unstable. But there is a chance that these patients probably will heal well, and even that unstable segment can become quite reasonably solidified, and it will probably become stable. At the same time, type of work, type of so many things are important in this. It's not only some patients are overweight, obese, where you can't give them a chance. If it is not symptomatic but it is unstable, you have to explain them that there is a chance that this will worsen, because these things matter. You just try to be very conservative and it worsens and patient loses. I have had a patient who was conserved and he came to me and similar unstable. It was a conus. Patient became paraplegic. He was told by me that you need surgery, and he was again seen by a couple of doctors. He went back. He came back in 2 3 days time with complete paraplegia. So you have
There
to
you
be
go.
very careful. I think it's a case-based situation.
Great. Great. Let's move on to our next speaker. Thank you, Nupam. And Dr.
I think
Vidyadhar
Dr.
from...
Vidya will start the shot with the conservative management, and that's very apt where we were discussing how much you can. So we'll start with Vidya, and then Dr. Ranjit's interesting case will take. Over to you, Vidya.
Can,
Dr. Vidya
can
is
you see my
a
slides?
yeah, Dr. Vidyadhar is a spine surgeon practicing at Manipal, and he's the chief of spine surgery, and he's a robotic spine surgeon, and he's done extensive work in surgical and non-surgical treatment of spine ailments. Over to you, Dr. Vidya.
Good evening, friends. I'll be discussing about my take on conservative management of osteoporotic fractures, both in theory and practice. As discussed by Anupam before me, I would like to reinforce the importance of detailed evaluation, both clinical, radiological, and labs, before deciding the course of treatment, be it conservative or operative. So do not miss the red flag signs. Do not miss tumors, infections, and especially myeloma. Before discussing the different components of conservative management, I would first emphasize that conservative management does not mean lack of management. On the contrary, you need to be more proactive with pain management, osteoporosis treatment, and follow-ups. There are multiple aspects of conservative management that we will discuss briefly. First of all is rest, advised only for the initial 2 to 3 days, which is supported by the strong evidence. Always aim to mobilize them early to avoid complications. So always encourage early mobilization after the pain subsides. And you need to consider multimodal analgesia. 3-point bracing, either Juvet brace or TLSO brace, is advisable for short-term, initial 2 to 3 weeks, only for mobilization and not for while lying down, and not advised for long-term. However, recent evidence doesn't show any significant advantage, but in practice, always better to brace for a few weeks. Pain management is the most important determinant of outcomes of conservative management. Commonly faced problems in this age group is achieving a balance between adequate analgesia and safety. NSAIDs, proven efficacy, but not preferred in elderly patients with comorbidities. Besides, known to cause non-union, so use only in the initial few days. Opioids and tramadol, good efficacy, but not very good safety profile in elderly, causes nausea, vomiting, and respiratory depression. Acetaminophen or paracetamol is best safety profile of all, but least efficacy for pain management unless you use it in the range of 3 to 4 grams per day. So most of the time we use a combination of all 3 classes of drugs to get the maximum pain relief with reduced risk. All anti-osteoporotic treatments have shown to be having secondary analgesic effects, although the mechanism still remains unclear. Commonly used adjuvants include calcitonin nasal spray, which has shown to have analgesic action and can be used as an adjuvant. However, current guidelines suggest not to use it beyond 3 months due to risk of malignancy. Similarly, bisphosphonates, teriparatide, and denosumab have also been studied with limited evidence showing good results. Now I'll discuss.
Try to go full screen. No, you're not full screen. Your next slide is showing up, so it's a bit unclear.
Is it now?
Yes. No, it's still not on full screen, but it's better.
Now?
No, now your slide sorters. Yeah, now this is fine. Go ahead. No. What you did a minute ago was fine.
It's not coming.
You just done it. It's at the bottom next to the volume button. No,
yeah.
Now you're
going up.
Now it's at the bottom right. Yeah, that's fine. Go ahead.
Yeah. This is the first case of.
You're back to presenter view, which is not a good thing because it doesn't show. Yeah.
This is a 70-year-old lady with a fall at home and came with the back pain. X-rays taken that time shows L1 compression fracture involving superior end plate type 3, where the treatment options are either conservative or cement augmentation. And most of us would agree that she would be managed conservatively with short-term bracing, analgesics, and anti-osteoporotic management of teriparatide. At 3 months follow-up, fracture started healing by collapse, no gross instability, and able to do her activity of daily living with mild pain of VAS 2 to 3. 9 months follow-up, fracture healed with collapse, patient pain-free. Although X-ray shows focal kyphosis with 30 to 40% collapse, patient was symptom-free and able to do activities of daily living. So this brings us to the point, treat the patient and not the X-rays. This is another lady with 72-year-old, similar L1 fracture, which had innocuous looking initial radiograph and was managed non-operatively with bracing and analgesics, presented to us 2 months later with persistent back pain, X-ray showing pharynx pseudarthrosis and dynamic X-rays showing opening of the cleft. So what next? Most of us often think when I showed both the cases of same L1 fracture managed conservatively, one healed and one didn't, there is still no consensus on what cases go on to non-union or instability. So it's important to know the natural history of vertebral compression fractures. Based on literature, more than 75% of them heal conservatively. Approximately 70% of the fractures heal with collapse and 20% without collapse, and 10% end up in pseudarthrosis. It is this last 10% where we need to predict which ones won't respond to conservative management. Some of the risk factors associated with pseudarthrosis are male gender, initial vertebral height loss of more than 40%, segmental cob angle of more than 20 degrees, junctional injuries, comminution, splaying on CT with PLC injury. In summary, the decision to opt for conservative or not decided on the combination of factors. Fracture morphology, neurological status are the most important determinants of management. Non-surgical management is appropriate if the fracture is stable and the patient can safely maintain mobility. With respect to pain and mobility, severe pain itself doesn't mean the need of surgery. However, the pain must be controlled well enough with analgesics and therapy to allow early mobilization. If they can't move, conservative care fails. Frailty factor, high frailty or severe osteoporosis doesn't automatically disqualify a patient from non-surgical care. It just dictates closer, more vigilant follow-up. The next question is, for how long should conservative trial be given? Initial trial is usually for 7 to 10 days, analgesics, bracing for 2 to 3 weeks, and osteoporosis treatment to continue. When to call up for patient follow-up? Call for the first follow-up after 7 to 10 days and assess clinically and with X-rays. When to change the approach if conservative treatment does not work? Most important is neurological worsening, persistent pain not allowing mobilization beyond reasonable time, that is 7 to 10 days, and follow-up imaging showing features of instability, either intervertebral or intravertebral. To summarize, 3 out of 4 osteoporotic fractures will heal with conservative measures. Conservative management does not mean neglect. It is proactive and supervised care. Do not forget the main pathology. Don't just treat the patient pain, always treat osteoporosis. I take this opportunity to invite interested surgeons to participate or attend in Spine Roboticon 2.0 in 5th and 6th December 2026 at Manipal Hospital, Old Airport Road, Bangalore. Thank you. I use this slide presenter view just for making sure I don't talk more nonsense and spend time stipulated, more than the time stipulated for me, Abhay. Thanks for
Okay, well done.
pointing that out. I think I shared the screen of my computer rather than the slide screen.
No worries. It
Anyway.
was a great presentation and it nailed everything on the point. Yes, Shailesh?
Yeah, I think so. Vidya, you were absolutely on the point, and what all things we normally do in our practice were covered. This is a very easy looking topic, but this is a very challenging situation when it comes to your actual practice and you are in front of the patient in the OPD. So I think I thought the best person will be Vidya, because the person who does a lot of advanced surgery he does a lot of advanced non-surgical treatment also, and that view has to come out. And I think it was very rightly done. Any questions for Vidya, Dr. Vidya? Vishal?
No, good to go.
Yes, Siddharth, anything?
No, I think it was well covered, including the practical points. I think the very important slide was that 3 out of 4 will heal, provided you just take care of treating the osteoporosis, which often we neglect most often, where the primary treatment is directed at fracture immobilization, bracing, and medications for pain management. And if you start the osteoporosis treatment in earnest at the first stage, a lot
Yeah.
of options in medical management have improved the treatment options.
Absolutely, absolutely. So I think we are gearing up very nicely, and I think we should. This is the right time where we should get Ranjit's case so that we can go on the medical management by Dr. Vishal Kundani. Because all these things will come up before your debate, which is again a most awaiting thing for this webinar. So I request Dr. Ranjit Unnikrishnan, again a stellar spine surgeon from Trivandrum, Thiruvananthapuram, and um, with vast experience of various difficult and deformity surgeries. Ranjit deals with a lot of osteoporosis and complex situations. So we will be happy to see what Ranjit has to say. Over to you, Ranjit.
Thank you, Shailesh and ASSI for the invitation. Glad to present with stalwarts. Can you see me, Shailesh?
We can see, but it is still not come. Yeah, yeah. Now we can see it. Yeah, perfect, Ranjit.
Okay, so I'll to follow presentation with the first speaker and Vidya about osteoporosis and how you can safely treat it non-operatively. Time and follow what we believe, and things don't go as we expect. So this was a lady who presented to us in 2022. She was 70 at the time of her trivial 2018, and she was a hypertensive. She had back pain, and this was the MRI taken then in 2018.
Ranjit,
So
your slides are not moving. We are
have you
on.
seen my first slide?
Yeah, it's the first slide only. Yeah.
You're seeing this?
Yeah, now it is. Yeah, now we can.
Oh, I think my
Yes,
internet
Ranjit.
is lagging. Can you see this? Can you see the slide now?
Yeah, we can see it now.
Okay, so this was a patient presented was in 2022 with she was 70 years when she sustained this injury, which was in 2018. She had a trivial fall, had back pain, and this was the MRI done then, and wherein she had an L1 percent fracture, which primarily looks very innocuous, and which the initial treating team decided to treat non-surgically, and she was then advised 3 months of bed rest, and she was started on medical management. I had no further details about what was. She presented us with in 2022 with gradually progressive kyphosis, difficulty in walking, and difficulty in eating. She was saying that I'm feeling hungry, but I cannot eat. I feel early satiety, but I'm very I'm still hungry. And this X-ray was in 2022. Shailesh, can you see the X-ray? Is my slides moving?
No, we can't see the X-ray. It's not moving.
Oops. I can just log off and log in from another connection.
Yeah, we
Is
can
it
see the
okay?
X-ray now. Yes, yes. Yes,
Okay, I
Ranjit.
think there's a lag. So this was the event it was in 2022, and you can, if you can see my cursor, you can see how belly been really pouting out and the amount of kyphosis. She was still balanced, she was walking, but her difficulty was back pain and difficulty in walking further. So naturally, her course of teriparatide would not be reforming. And then decision to go with surgery because she was elsewhere, she was very healthy. So we know all these rules when we speak about kyphosis. We think about LIV, should be SSV, should it be the first lordotic vertebra. We think about distal junctional kyphosis. We talk about, can we prevent a PJ? we look at, is it an acute angular kyphosis or is it a globular kyphosis? You think about the flexibility of thoracic kyphosis, and then you think about the extent of osteotomy you have to do if it is a rigid kyphosis. We also think about, should we do an anterior surgery or a posterior surgery? So all these really does not matter when it comes to osteoporotic kyphosis. What really matters is the flexibility of the thoracic or the thoracolumbar kyphosis. This is one single thing which matters, because rest all is actually basic surgical planning. And most of the time, if you come with a late this kind of deformity, there is no focal correction. It is getting her balance at one go, because she's at 25, 74 when she came to us, and you don't want to her be lying down in the even for a day surgery. So, contrary to what Dr. Das was mentioning, this is an X-ray which we get it done when we are planning any kind of surgical correction for a late onset kyphosis. Can you see my X-ray? See my slide, Shailesh? I'm sorry, I have to ask because
Yeah.
so we typically get this forced hyperextension bolster view, wherein a bolster is kept at the apex of the thoracic kyphosis and the patient is made to lie down. We don't take an X-ray immediately, give at least 4 to 5 minutes for the muscle spasm to disappear and the patient to lie supine. And then we get a cross-table lateral X-ray. What the factors we exactly look at are, we look at the apex, then you look at the discal plane. Is the opening happening at the vertebral body, or is the disc phase? Applying what Dr. Abhay Nene has published, is it an intravertebral instability or an intervertebral instability? Or is it a combination of both these factors? If we look at the opening up of the disc space, look at the flexibility of the rest of the part of the spine other than the acute kyphotic segment. And in this particular patient, we decided to go ahead with a cement augmented post-instrumentation with multi-level posterior column osteotomy, and to go from T2 to S2AI, because that's what we needed, our typical location, how we take in the patient positioning. And this is what we did. We went ahead, put fenestrated screws at every level other than S2AI, because I didn't want cement leaking into the pelvis if my S2AI screws out. And this is after cement augmentation, and we went ahead doing segmental osteotomies. Can you see my slide, Shailesh?
Yes,
Is it
yes.
Okay, I think so. And this is what, after we did our entire osteotomy correction and we lay all the onlay grafts extensively from T2 to S2AI. And this is what we get immediately post-op. So you can see the surgical drain in the patient. She's standing up on day one post-operatively. You can see how we could restore her balance back. Still, she went from positive balance to a bit of negative balance. It's very usual when you do this kind of correction each day one. And this is how she corrected eventually from 2022 to 2026. I still have follow up on her. She's alive. She's now 78, 79. Happy, very happy with the surgery. And we did continue to give another 1 year of teriparatide, even though total 2.5 years of teriparatide for whatever worth it may be. And she could restore her balance back beautifully. So if you look at the kyphosis in OECF, it is very much like tuberculosis. Today, we have a shift in the paradigm from early medical management to prevention or minimizing deformity. So if you know the red flags, as the first speaker mentioned, if you know to look at the MRI red flags and treat them actively early, we can minimize such huge corrections or huge surgical corrections by doing a minimal job. So it's very much like a TB lesion. You get an active disease, very like a wet lesion in tuberculosis, or we can have a post-tuberculous kyphosis picture, similarly with a post-osteoporotic heel disease. But most of the time, it's a mixed disease. Part of it being vertebral wedging, part of it being discal opening, and part of it being pseudoarthrosis. The third type is the most common type. So I would show a type. This is an acute kind of kyphosis, which again presented again. Can you see my slide again, Shailesh?
Yeah.
Sorry. If you see a focal lesion, we got a supine cross table lateral. We could see that the whole thing was opening up at one vertebral level. And such cases, we don't have to restore to this huge kind of surgery. So we went and did a vertebral standing, which was at that time kind of standard. We could correct her fairly well. So all in all, what is to keep a patient balanced and straight. So if you see very critically, OS, as we know, is a focal presentation of a systemic disease. So medical management is at most, it is fundamental. Like we discussed some time back, 2/3 to 85% of them will heal uneventfully. The job of the surgeon is to enable to have an acceptable deformity. We can never say that they will not have a deformity, to have an acceptable deformity. When there are red flags, we have to go in early to minimize the final surgery or to minimize the deformity. And at times when they're present in late, we may have to go full Monty with these heroic things to restore them to an acceptable balance. Thank you very much, Shailesh, and questions.
Great aggressive talk, Ranjit. And the first question is, do you live in Germany? Question mark. But anyway, that was a lovely case also. I think the immediate question I'd like to ask you is, what are your indications, or what would you suggest are the indications to do surgery for osteoporotic kyphosis?
So if we have treated them at the early stage and the patient has healed with an acceptable kyphosis and the patient is happy with it, there is no point treating the kyphosis. So when you come into a state in which patient who present in late in spite of appropriate medical management and it affects their quality of life, most of them whom I have to treat, these are the people who says, doctor, I cannot sit straight or stand straight or eat well. Early satiety is something which I really see quite often in these elderly age groups with the belly bouting out. They also have a bit of osteomalacia, so muscular weakness. So therein I will go in and treat them, and if they're medically fit and suitable to anesthesia, I'm fairly confident of doing a quick job in them. I'll be happy to correct them one.
Superb. I think, Ranjit, the case itself spoke a lot about and a lot of learning points for all of us. I think your planning and execution is excellent, and I am sure this patient is doing fine. But how, after surgery, how we treat this patient medically, and before surgery also, a lot of non-surgical patients. Medical management is again a very, very important topic, and we are waiting for hearing it from Dr. Vishal Kundani, again a very, very academic and stellar spine surgeon from Leelavati and Bombay Hospital, Mumbai. Is Dr. Kundani around?
Yes, very much, Shailesh. Am I audible?
Yes, hi Vishal. Yeah.
Hi, everyone.
In the interim, can I just put a small question to Ranjit?
Yes,
Yes.
sir.
Ranjit, do you do this supine force bolster view on most of your patients, or
No, sir.
is there a
No, sir. When they come up which they want to be done something about it, at that time I do a supine cross table lateral. I never do it at early part of, because it's going to open up. So when they come at like 3 months, 4 months, after all the adequate medical management, they still have, when I look at the primary MRI, I did not see any red flags. I conserve them, or somebody conserve them. They come with kyphosis. And when I'm planning to do any kind of surgical intervention, at that point, I get the supine cross table, because it lets me decide, should I go in for a focal treatment or a global treatment? If it is a pure intravertebral instability, which opens up very well, I can go ahead with a vertebroplasty with cement augmented short segment correction. But like this case which I did, which I discussed some time back, which comes in late with a multi-second globular kyphosis, any kind of vertebroplasty will not open them up. That needs to be corrected. So there I have to make a decision between, do I do a posterior column osteotomy multi-level, or do I just do some? So at that point I get it corrected. I see it significantly. I never do any anterior procedure for osteoporosis, because most of the time it is a disaster in the long term. I had to, earlier ones when I tried heroic things, I have to revise them. So always to go from the back and try to go long segment, multi-segment, short column osteotomies, sipping it off augmented screws, which gets a balance back.
Thank you. Okay.
Okay. Over to you, Dr. Kundani.
Are my slides visible?
Yes.
Okay, perfect. I think what Dr. Ranjit highlighted, is my slide visible now?
No,
No.
Oh, I'm so sorry.
you are visible.
So what Ranjit highlighted is that the longevity of these all these cases, the results that are produced by surgical maneuvering, they all last not on how well the surgery was done, but how well they were managed medically, pre-operatively and post-operatively. Ultimately, osteoporosis is very much like tuberculosis. If you don't treat the medical problem behind the osteoporosis, you will lose the battle, if not now, very soon. And the problem with osteoporotic medication, which we all know that it's a medical problem, it requires medical treatment. The problem with the medical treatment is that there are no strict black and white guidelines there. And there are so many molecules that rather than giving us a consensus, it gives us a confusion. There are anti-resorptives. We have been using bisphosphonates for donkey's years. We have been using oral, injectable, and various formulations weekly, monthly, and various whatnot available in market. And none of them have really served the test of time. However, they are still big and prevalent in the market. The newer molecules like denosumab and romosozumab have taken the market in the form of anti-resorptives with their own pros and cons, along with other anabolic agents which are available. Yes, there are other non-usable molecules like estrogen, SERM, strontium therapy available. But the most important molecules that currently are in vogue are anti-resorptives and anabolic agents. And we'll be discussing about them in detail, about when, what, how long, when to start, and what to consider while starting these molecules. Because these questions, whenever you think about medical management, be it a conservative management of osteoporosis, or be it pre-operative optimization of these patients, or post-operative management to prevent implant failure or loosening in these patients, these questions will often come to your mind. When to start, which one to start with, how do they actually work, whether should I give it in combination to begin with, or it should be a solo therapy to begin and I can shift to combination in middle, and how long do I give which molecule. And the most important thing, when do we consider that there is a time, this is the time that we have to change the molecule there. To this, I think this one slide that most of the spine surgeons now have learned to emphasize more than any medical management, and which works like foolproof prevention and cure for osteoporosis, even in pre-operative or after surgery, post-operative patients, is prevention of fall modality. 90% of these patients have either had a fall or they will have a fall sooner or later. And if these home changes can be done, I think this is something that will prevent the immediate acute loosening of implants in post-op patients, and also will prevent a second fracture from happening. And this prevention of fall modality is very simple, by simple advices given to them with the emphasis of no loose rugs in home, railings in bathroom where most of the falls will happen, avoid wet surfaces, keep a bed switch besides you, and correct the eyesight. These small measures play a very important role, and research has proven that 73% of falls can be prevented if this is emphasized on weekly basis in these patients who have had a fall related osteoporotic vertebral fracture. And of course, vitamin D supplementation, encouraging muscle mass development, correcting sarcopenia is something that will make them injury prone. I mean, they can still have a fall, but they will not necessarily develop fractures, which will be grotesque and morbid, requiring intervention. So this is something that has become a protocol over last decade, that every patient, irrespective of what molecule we give them, whether anti-resorptive or anabolic, this goes like a printed sheet on the patient, that prevention of fall, development of protein, development of muscle mass, and strength training is bare minimum beginning of osteoporosis treatment, whether it is pre-operative or post-operative in these patients. Now, when it comes to medication, the simple rule is start at the earliest. It's like tuberculosis. The moment you suspect it, you start treatment. Even if you don't biopsy it, start treatment. Ideally, you should confirm that you're dealing with the osteoporotic medication or osteoporotic disease and start it then. However, in osteoporosis patients, we have a levi to diagnose it clinically, and that is means 5 years post-menopausal, more than 2 risk factors, they satisfy the criteria clinically. You don't really need an investigation to satisfy that they are osteoporotic, and you can start treatment even if it means empirically. So don't wait for the fracture to come. If there is an osteoporotic fracture, it automatically classifies into a severe osteoporosis requiring any kind of aggressive osteoporotic treatment. Remember, it is not the fracture treatment that we are aiming, but the aim is to prevent secondary fractures and healing of this primary fracture to reach the levels of the case where what Ranjit just mentioned and showed to us. On one hand, when we say it is empirical, it doesn't mean it is casual. Empirical means you can start without investigation, but it doesn't mean you can just start left, right, and center without any consideration. You have to start osteoporotic medication with a detailed consideration related to every molecule. There are some molecules which fit in one category, there are some molecules which are strictly contraindicated to another, and there are some molecules which can be given for long run without any major consideration. This is what we need to know, what I commonly call it as the feasibility of use. So how do we understand the feasibility of use? A basic bone metabolic profile is absolutely recommended even before you start any kind of treatment. Now, why is this important? Is because we all know bisphosphonates, anti-resorptives are known to create hypocalcemia. You start a patient with hypocalcemia on these bisphosphonates, you will have disasters coming in. A patient with high PTH level, you may actually create bigger problems by giving them teriparatide. A patient with a high creatinine level, giving them bisphosphonates in the form of injectables, you're going to create more complications rather than the benefits of them. Again, the oral bisphosphonates don't go well with patients having gastric issues or asthma, whereas injectable ones work wonders in these patients. So these are basic feasibility of use checkpoints which you have to ascertain and have a green check on them. So start early, start on clinical suspicion, but always check feasibility of use before you start any molecules, and always keep checking a DEXA scan at least, if not 24 months, which is ideal, but at least in 12 months time. That is something that to monitor whether the therapy is working or not in these patients is absolutely mandatory. Now, anti-resorptives are the first line of treatment. A clinical suspicion without having an obvious fracture, but multiple joint pains, myalgias, more than 5 years of postmenopausal status, multiple aches and pains here and there, night cramps are all symptoms which should raise a suspicion in your mind that this patient, even if there is a specific diagnosis of degenerative spinal cord compression or any compressive myelopathy or even lumbar canal stenosis, if there are non-specific symptoms which are unexplainable, which may have a cause in the form of osteoporosis, please don't hesitate. These are the patients whom you may want to start anti-resorptives if there is no acute fracture that has been diagnosed in recent times. However, if there is an acute fracture already diagnosed in recent times, again, anti-resorptives can still be started. Of course, because it classifies into severe osteoporosis, injectable therapy is more recommended in these patients. Now, when it comes to anti-resorptives, remember there are multiple options. It can be in the form of weekly, monthly tabs, or 6 monthly denosumabs, or yearly zoledronic acid in the form of IV given. You can choose any of these molecules based on the profile of the patient. The bisphosphonates orals don't go with gastric issue patients or in patients with asthma. Even zoledronic acid injectables do not go well with patients with COPD or fibrosis. Again, patients with dental treatment or patients who have hip issues, please don't use zoledronic acid injectable. They can lead to osteonecrosis of jaw and such situations. In those patients, anti-resorptives in the form of denosumab comes very handy. Denosumab also comes very handy in long-term maintenance therapy. And if patients have had an acute fracture, start with the injectable anabolic therapy patients. Remember, please do not use these bisphosphonates in acute fractures in young patients. This is not something that you want to treat them with in acute patients. Acute patients, you should not use it because anti-resorptives are the ones which will prevent the consolidation of the fracture in acute phase, and that is why it should be started only after feasibility check is confirmed, calcium levels are okay, patient is fit, no gastric issues, no renal issues, and only then you start in these patients, and that's when these will have the best effect. Patients with high creatinine level, low calcium levels, it's a strict contraindication. Please don't use them. And remember, on bisphosphonates, always give supplementation of calcium. Patients have a high tendency of developing hypocalcemia, further creating deteriorating effect on bisphosphonates alone. They all work with bone resorption, but denosumab in particular prevents bone resorption, and it is to be given once in 6 months. It has less gastric and respiratory side effects, and that is why in patients where bisphosphonates are contraindicated, it comes very handy. The another advantage of denosumab is that it can be given as a prolonged therapy. FDA has approved the use of denosumab in the form of maintenance therapy for as long as 8 years currently. So there is a recommendation that up to 8 years it can be used safely without any major side effects. However, in patients with resistant to PTH, this is specifically indicated. In patients with creatinine clearance issues also, this is a very safe molecule. It can be given very, very safely. The only downside of this molecule is that, one, in current times it is costly. Second, it is to be given in injectable formats, and sometimes it is known to create to cause more bone resorption than another thing. Now, anti-resorptive efficacy has been proven both in hip fractures also and in spine fractures also. However, in spine, combination therapy works better than only anti-resorptives. And it has been proven in multiple studies that only use of bisphosphonates has resulted into more prevention of fractures in hip rather than in spine cases. Whereas in spine cases, anabolic agent or a combination therapy has prevented second fracture happening better than only this anti-resorptive therapy. And that is where not only prevention of fracture is really, really helpful by using anabolic agent like a teriparatide, which is the game changer and for the last decade of preventing new fractures, but also being one of the most prevalent and most strongest bone forming agent, anabolic agent, which stimulates osteoblasts. It results into increased architecture in the bone density. It really results into bone mass formation in doses that are mentioned. It is to be given daily in the form of subcutaneous injection. Recommended doses, so far FDA approvals are there for 24 months, but now approvals for 36 and 72 months are also in place. So there are cases where up to 3 and up to 5 years use is also permitted. However, FDA approvals are only available till 24 months. The one thing that one must avoid using this molecule is in patients where there is already a high teriparatide levels, particularly in patients with some kind of metastasis. And that is why checking the teriparatide level, parathyroid hormone levels pre starting this molecule is extremely, extremely important. And always check calcium and creatinine before you start. Patients with high alkaline phosphatase, high bone turnover situations like Paget's or in metastatic diseases, try to not use this particular molecule. It can create more problems like anything. When to start? I think this molecule comes into picture immediately as soon as you see a fracture, even when the BMD is low. Don't depend on BMD. Don't rely on BMD to start a teriparatide molecule. You don't need a BMD to go minus 3.5 always to start this molecule. A definition of a fracture in itself is enough to say that the patient has got severe osteoporosis, and you can start it day one, the moment you see that there is a fracture, after the feasibility of this molecule is checked already. And there are plenty number of studies that not only individually teriparatide has been proven to stimulate bone formation, bone architecture, and bone mass. It also results into improvement of the muscle mass in these patients when given in low doses for long term. A newer molecule that is making big news and is already available in India for last 3 years now, which is romosozumab, available with few pharma companies only and have a monopoly currently and very, very high pricing, is romosozumab, which inhibits sclerostin. It's a monoclonal antibody, inhibits sclerostin. Not only it prevents bone resorption but also stimulates osteoblasts. So that means it is like a dual therapy working simultaneously. It not only results in bone formation but also prevents bone resorption. So it is an anabolic anti-resorptive agent and has shown wonderful results in most of the studies that are available currently. Also in practice, we have seen really good and humongous bone formation around these fractures, and then given started early can really make a big difference in prevention of deformity or neurological deficits, and plenty of studies have also proven it. The only biggest problem is patients with compromised cardiac status have shown a very high incidence of cardiovascular risk. And that is why even before you start this molecule, having a normal ECG, a normal 2D echo, and no previous cardiac incident becomes an absolute rule. And that is why the need and the role of this molecule gets limited to only those patients with normal cardiovascular status, which in current times with patients in geriatric age group, the role becomes very limited to a limited group of population. Which one to start and when? I think asymptomatic patients with symptoms which are very minimal in nature, with no fracture, bisphosphonates weekly oral, if they set in the criteria. If there is a fracture, start with teriparatide and maybe combine them with an anti-resorptive oral or injectable. And maintenance therapy after you have burnt out your teriparatide comes the denosumab. Romosozumab is particularly useful in those patients where there is a contraindication for denosumab or for teriparatide. That's when the molecule becomes the primary molecule to start with, again after a check has been done in such patients. How long? Bisphosphonates for 2 years to 5 years is recommended by FDA. Teriparatide current guidelines FDA approvals are for up to 36 months, but there are already studies which show that up to 5 years it can be used safely, and the benefit continues to come year on year even after 36 months. So there are rare studies, but currently it is shown that the maximum peak effect comes between 12 to 18 months, and after 24 months the benefit is only in the form of maintenance therapy. Denosumab can be continued for lifelong. Up to 10 years it is recommended. However, it is to be given at only once in 6 months intervals. And how to monitor therapy? Measure calcium levels every 6 weeks. That's the bare minimum. You don't want to have a hypocalcemia on anti-resorptive therapy or even on teriparatide therapy. Take calcium levels at least 6 months. If you feel that the expected outcome is not there, that's when bone marker, bone formation marker and bone resorption markers is something that I use in practice. Although there are recommendations to do it in the initiation phase in 3 months, after first 3 months of therapy, to see whether these therapies are working or not. However, I generally use it only when I see that the clinical benefits are not very evident in first 3 months. That's when these blood tests come into picture to see whether the therapy is working or this is a patient with teriparatide resistant osteoporosis. And if in 1 year the BMD or the symptoms have worsened and the patient is deteriorating clinically, or there is a new spontaneous onset fracture, I know that I am dealing with a resistant osteoporosis which is not doing well with this medication. I always follow combination therapy rather than solo therapy, particularly in patients with osteoporotic fractures who have established fracture there. And this has really shown superior results to any kind of monotherapy. For me, teriparatide and bisphosphonates combination works wonders. And when to change therapy? Only when we suspect that it is not working, particularly in patients where there are comorbidities like smoking, alcohol, or patient serum period teriparatide levels are parathyroid hormone levels are very high. These are the times when we want to change from teriparatide to other molecules. So to summarize, osteoporosis is a medical disease. It requires medical rules. It requires medical management. Treatment can be started empirically, but it is not to be maintained or treated casually. It has certain considerations to be made. General care and fall prevention is extremely important to prevent a secondary fall better than any other molecule. And there are various molecules, the rules and guidelines in the form of consensus statement is yet to come. But I am sure these few slides will enhance our understanding about these molecules to come to a consensus. Thank you, gentlemen.
Vishal Vidyadhar here. I have one question for you.
Yes.
It was an excellent presentation. I think you have spoken the highest of levels of pharmacological parameters, and I don't think even a company person can know so much of details about every drug that has been used. Anyway, my question is very simple. Like, say, is there a difference in choice of anti-osteoporosis treatment if you have a 35-year-old with minus 3.5 versus 75-year-old versus 95-year-old? Do you start with X drug first, Y drug in the second, Z drug in the third? And what's your follow-up plan with which drug?
Excellent question, Vidyadhar, and really I'm so happy that you brought this up, that osteoporosis may have different colors, and that is why at different age groups, the cause will surely be different. A normal 35-year-old male developing osteoporosis has to mandatorily have a cause behind it. Either
No,
it's a
anybody
renal,
post-hysterectomy or somebody on steroids post rheumatoid arthritis.
precisely. So whether the patient is on medication driven, whether it's a drug induced osteoporosis or whether it's a parathyroid hormone deficiency causing osteoporosis, or it's a osteomalacia causing osteoporosis, or there has to be some reason for a young non-conventional osteoporosis. Osteoporosis is not a young man's disease. And similarly, if the patient has smoking, alcoholism, some drugs, then taking care of these molecules become your priority. All these molecules have to be taken into consideration. Steroid, how can you lower the dose without affecting the need of steroids benefiting the other disease patterns? Like in rheumatoid arthritis, if patient is on steroid, you can't abruptly stop it. At the same time, you can't expect that a steroid-induced osteoporosis is going to behave similarly as it is going to behave in a patient who's not steroid dependent. So for all these patients who are asymptomatic or mildly symptomatic, age doesn't really pushes me to push my boundaries. If a patient has severe osteoporosis, which means BMD less than minus 3.5, teriparatide kicks in. If a patient has a fracture irrespective of BMD values, It is called severe osteoporosis. Dr. Abhay has taught me this, that you don't need a definition of osteoporosis to be severe, mild, moderate. A fracture cries for it that I am a severe osteoporosis, and you have to kick in teriparatide treatment immediately. So that's my beginning point in severe osteoporosis. For mild to moderate, bisphosphonates statin and orals preferably because they have a better compliance. Injectables if patient is not compliant, non-tolerant to it. And as I said, denosumab is the molecule of choice if patient is intolerant to any oral bisphosphonates. And romosozumab kicks in only when severe osteoporosis, irrespective of age, but contraindicated teriparatide or contraindicated denosumab.
My second question, say you have a lot of medical specialists who do treat osteoporosis. Like I told, one condition wherein 35-year-old with rheumatoid on steroids, on disease modifying drugs, and so many interactions may be there with all these drugs that you talked about. Or say somebody who is a cancer patient, say myeloma with osteoporosis with a fracture, you have treated the fracture. So do you treat still the osteoporosis, or do you hand over the patient to the medical specialists who are, that's their bread and butter, I guess?
So again, Raghavendra, I would say that handover is a process which is only a formality. Unless you want to really get rid of the patient, you tell them, go and see them, don't come back to me. But in our scenario, there is no handover officially that happens. It is always a multidisciplinary thing. Patients have back pain, patients have symptoms, they are bound to come back to you. Whether you should involve an endocrinologist or not is a question that you should ask yourself. Are you comfortable treating not only this osteoporosis, which is medical in nature, with the molecules that you intend to give? Are you comfortable to handle the scenario well or not? The scenario that you mentioned, patient on steroid onset osteoporosis, patient with multiple DMRDs, patient with other medical problems. My job is to start him on treatment, send it to an endocrinologist for an opinion if there is something that I'm missing upon, and this patient is bound to come back to me. And if he comes back to me, I will not tell him, no, go away again, don't come back to me again. He's got back pain, man. It's a domain of a spine specialist. And a spine specialist is not only a spine surgeon. We all need to learn these nuances of medicines like we have learned the nuances of simple tuberculosis. But when it comes to MDR TB, we do take the opinion of a chest physician or an infection specialist and still work in liaison like a multidisciplinary team. And that's what I do. A complicated osteoporosis, molecule driven, drug induced, with multiple such scenarios, an endocrinologist kicks in as a team member, not like a solo member, because he will also need
Thank you, Dr. Kundani.
Thank you.
Amazing. I think this was a wonderful explanation, and Dr. Vidya for this interaction. We are receiving so many calls. Dr. Gandhi is in Canada and he's watching it, and he's very much amazed, and he's telling the discussions and the talks are very good. I think we, in the want of time, we'll have to go to the next hot debate, and the age-old problem which we all are seeing for last 20, 30 years is vertebroplasty, which we are doing successfully with some problems. Kyphoplasty, we are doing successfully with some problems. So let's hear it from the horse's mouth. And we are here with Dr. Siddharth Iyer from Pune. We'll be talking about his experience on vertebroplasty and why he chooses versus the giant from Delhi. Dr. Das will be speaking about his wholesome experience of kyphoplasty. Over to you, Siddharth.
Thank you, sir, for that opportunity. So, is the screen visible?
Yes.
Yes. So today's debate is vertebroplasty versus kyphoplasty. So I will be presenting for the case for vertebroplasty. So the objectives is, what I've done is a basic review of evidence for both techniques. We'll compare some of the clinical outcomes, discuss the procedural efficiency of both, and examine what complication. And hopefully by the end of my talk, I can put forth the case for vertebroplasty, which should remain the preferred choice of cement augmentation. So is my screen visible still?
Yeah, screen is visible. Yes.
Not moving, but.
Not moving. Yeah, not moving. You can re-upload, Siddharth.
Yes. Yeah. So, and then make an explanation for why the vertebroplasty should be the preferred option.
Okay. We are
Is the
with you.
screen now seen?
Yeah, yeah. It's not moving, that's the thing.
Yeah.
Maybe the internet is bit weak, yeah? Try one more time. Yeah, we are seeing your screen. Or we can take Dr. Das in the meantime.
Yeah, I'll just log out and log in into the meeting again.
Yeah, yeah. Das sir, can you please share your screen?
Yeah, just give me a moment.
Yes.
So now these are actually archaic debates wherein whether kyphoplasty or vertebroplasty should be the option of treatment. We are very well aware that the indications of kyphoplasty or segment augmentation has reduced to the indications have become very small. A. Two, the preference of procedure depends upon the surgeon and the particular problem in terms of the fracture that is presented to us. So if you take this simple case of a fracture which is at L1 and this is the I can hear somebody's voice. I think it's Krishnan, Muni Krishnan. And this is a similar vertebral fracture. I do a 4 to 6 weeks prone lateral, or if the patient has not increased pain, which is a concern of us of a recollapse, the prone lateral shows it's opening up, then we do a kyphoplasty for this patient. Now, to debate a kyphoplasty and a vertebroplasty is like comparing oranges and apples, because you are looking at a sedan car which has 8 seat backs, which is German manufactured. You have the outcome, you have the roads, you have a desire to drive, you buy a Mercedes for yourself. You want to commute from A to B point and you're not concerned about the safeties or the comfort of the drive, you can as well go by any sedan of your choice. So trying to compare why a vertebroplasty, see, the end result is neither of these, both these procedures have a very small indication. One, it fills in the fracture. Neither of them increase the fracture height. Both decrease pain by the cement and acting on the sinovertebral nerve. Both give a temporary solution to the indications they are. Both have the same sort of instruments that is used. This is like everything being the same. You choose what sedan car you or what SUV you want to buy. So if the patient, and let us always not talk about that my patient is poor and he cannot afford a particular treatment. So the safety concerns of the kyphoplasty edges out on the vertebroplasty. You can do a double balloon technique in which you can create another wall. So these are like some failed vertebroplasty wherein you inject a liquid cement to fill up the space. If the pressure of the cement is such that it can fill up a space, it is also possible that it can extravagate to other spaces, including the disc. So these things have already been talked about. Kyphoplasty, vertebroplasty, the indications remaining the same. The contraindication also remains the same. Procedures minus the balloon, I think the procedure and the instrument are the same. Most of us, at least I like to do my kyphoplasties in a supine position, in a prone position, in an awake patient. So there is a biofeedback when I'm passing the instruments. A lot of people have their own choices of anesthesia. The only contraindication to kyphoplasty, I feel, is if the patient cannot be positioned supine. So these are the techniques which remains the same for both the procedures. The only difference that I would feel is in the safety output of the conditions. The cement, which is a more toothpaste-like, is well fitted into the space created by the balloon. The balloon also creates a mesh in insufficient fractures in which there is a lateral blowout or there is an anterior wall. So if you do an eggshelling technique, like you put in a little liquid cement, if there's a lateral breach or the anterior breach, you can make a liquid cement, put in the balloon once again, and again create a shell in which you can fill in the cement. So these are the outlet advantages and a safer procedure of a balloon kyphoplasty. And this is why I would choose a balloon kyphoplasty in an already fragile bone to fill in my cement wherein a space is made rather than injecting a liquid cement in high pressure. I thanks and I rest my debate. Complications remain the same for both of them. Thank you.
Nicely said, Dr. Das. I think the ball is in Siddharth's court. Is Siddharth around? Can you share your screen?
I'll just stop sharing my screen so that.
Yeah.
Just a moment. I need to. I'll again rejoin. I think there's something wrong with the net. Just a moment. Again, the same. I'll again rejoin. My share screen is again coming back, but
log out, no? Log out and log in again.
Yeah, I'll do that. Yeah.
Yes, Siddharth. Yes, you are seen, Dr. Iyer. But probably you are muted.
Yeah, sorry. So my screen is not moving.
Okay.
Let me try once again.
Try once again. Even if the side screen you can show, Siddharth, that is also
So
fine.
I'll just move it without going into screen slide. I'll just the slide might
that
be...
you can do. What you're doing is right. That only you can.
Whenever I'm
Now
going
we
to
can see
slideshow,
second
it is not allowing me to move
Don't
for
go
some
to
reason.
slideshow. This is good enough. Yeah.
Okay.
Yeah.
So yeah, thank you again. So we've just heard Professor Das, Khalida Das. I will just give some rebuttal. So yeah, objectives for reviewing evidence of both comparing clinical outcomes and what is the efficiency, and then examine complications. So largely we understand that this is selected indication, like Dr. Das mentioned. We will be attempting to do this only in the DGOU 1, 2, maybe in some of the 3 with a very relative indication extent there. But for most cases where 4 and 5, where you have seen Dr. Onni Krishnan throw a very flamboyant multi-level fixation, those is where a cement augmentation will not stand. I feel that yes, there is a difference between a Mercedes car and a regular sedan. But at the end of the day, for as far as vertebroplasty and kyphoplasty, I think they're still hum iki thali ke chatte batti. It's a percutaneous procedure. It is minimally invasive. It is about trying to recreate a small void where a big job need not be done. Most of your patients are elderly. You don't want to subject them to general anesthesia. There is even a question कि बाबा वो पेट के ऊपर लेट पाएगा या नहीं. So if we are talking about all of these type of scenarios where they're very frail and the ultimate aim is only to fill cement into the void, then if you can get away without needing a balloon with a simpler cost, why not? So both procedures definitely provide similar clinical benefit. Then in such a case, a simpler procedure in maybe a high risk individual still stands to hold good. The literature equivocally has not been able to prove superiority of the one procedure over the other. Now, this is going back all the way to Lancet in 2009 to current day meta-analysis published in Spine in 2021, where both find pain relief is similar, disability improvement is likely to be similar, need for revision and mortality results are also quite similar. Eventually, quality of life also sometimes is dependent on how well you treat the osteoporosis, not merely whether you put the cement without the balloon or you have put cement with the use of a balloon. Pain relief, तुम भी हैं, हम भी हैं, same immediate improvement is both good. There is no long-term difference. So if you say vertebroplasty versus kyphoplasty, 2-year result, 5-year results, I think the osteoporosis and the severity of osteoporosis, how well you treat it with anti-resorptives or anabolics determine the long-term quality of life. So as pain relief being the primary objective in an elderly, frail osteoporotic fracture, I think vertebroplasty and kyphoplasty achieve a similar result in the early onset, early course of the disease. It's important that one of the key reasons that kyphoplasty has been suggested is restoration of height. I do agree in early and acute fractures where vertebroplasty, if you have to attempt, you need to maybe have higher injection pressures. In that case, by the balloon actually impacting the trabecular bone, it does improve the height restoration to some extent. But what is the end result of this height restoration? It has not been proven that a better height restoration correlates with better pain outcomes and improved functional outcomes. And eventually the osteoporosis, if it's not treated well, the kyphosis still can worsen and the correction may be lost over time. So we are here to treat our patients and not their radiographs. So better looking height restoration may not eventually justify the means. Procedure and time, although both are percutaneous procedures, both are fairly quick procedures, both can be done under local or sedation without the need of a full general anesthesia because the procedures are short inherently. But still, the insertion of a stellate with the balloon, inflating the balloon, removing the balloon, that does procedurally add maybe 2 or 3 steps more than entering into a vertebroplasty in a pre-formed cleft. So in the elderly, a shorter procedure may be of importance in the long run. So it may not add to many hours or something like that, but it's still minutes is what you save or shave off while doing a vertebroplasty. So the cost is one of the main reasons, like Sir said, that you can have an expensive car, you can have a cheaper car. If you want to get to point A to B, I think any car will do. But if you want to have a very upgraded, recent technology use, then yes, the balloon system with a higher implant cost can be one factor you can think out. But to take home the message, equivalent outcomes may not justify substantially higher costs in terms of the procedure. The common criticism for vertebroplasty is cement leak. Yes, it does happen. But if you do it in a well-formed intra-lesional pseudoarthrosis or a cleft, then the chances of cement leak are very less, provided you are technically using that endpoint that you are using a doughy texture and not inserting it in an extremely liquid phase. So those are technical issues at the level of performing the technique, but necessarily cement leaks will not happen otherwise if you're being careful. Most often cement leaks, like we can see, we have in kyphoplasty also. Quite often they are asymptomatic, but symptomatic cement leaks with neurological injuries are considered rare. But in acute fractures, if you're doing the cement augmentation on day 1 or day 7 or day 10, then I think you should be very careful when you're trying to use a vertebroplasty. But if these are coming at a subacute stage after say 2 or 3 weeks, most often there is enough fibrous tissue to prevent any cement leaks. Adjacent level fractures, I think this has been quoted again in literature, but there is no consistent difference. I think both vertebroplasty-led treated patients and kyphoplasty may have adjacent segment fractures. It is inherently down to the biomechanics of the fracture and more likely due to the osteoporosis or its management that will determine how many adjacent level fractures and how often they occur. What do our peers say? So we have national guidelines by the North American Spine Society or the International Spine Association for Spine Surgery. Both support cement augmentation procedures in selected patients of osteoporotic fractures. Neither of these societies recommend kyphoplasty over vertebroplasty. Neither they deem both procedures to be appropriate in appropriately selected individuals. So there is no evidence of superiority of one. So I prefer to offer a cheaper alternative to my patients. So in summary, there are lower cost, simpler techniques, shorter procedure, less equipment, similar pain relief, widely available, equivalent functional outcomes. So it does seem to suggest that a vertebroplasty well done is equally good. So in our arguments, we will have more leakage, no height restoration, technologically superior, more up to date. Vertebroplasty is an older procedure. But then if an older procedure has stood the test of time, and if we are still having a debate on vertebroplasty versus kyphoplasty, the mere fact that it stayed in vogue is also suggesting that something is right about this procedure. Yes, the most important question is the patient an ideal candidate for a cement augmentation procedure? I think if he is, he will do well with the vertebroplasty and he will do well with the kyphoplasty. He might be poorer with the kyphoplasty in terms of the amount he has to shell out at the end of the procedure. They are to be used for subacute fractures ideally with an MRI confirmed intravertebral cleft, which is the best. Both will have good, if they're pain refractory to conservative, they are good for good candidates, especially in the elderly, frail, who have other multiple comorbidities. And procedurally, the simplistic procedure does have an advantage over the complex one. These are my references. And thank you for your patient listening.
Wonderful. I think both the debaters were point on, and you all both made your point beautifully. And I think you both summed it up well. Thank you so much for that hard work, Dr. Kalidat and Dr. Siddharth. It was very, very enriching, and it's all this resources going to stay on YouTube for everyone to refer back. For want of time, we're going to quickly move ahead and segue into an interesting case by, again, one of our rock stars of Bombay Orthopedic Society, Dr. Rohan Gala. And that's going to be the penultimate for this session. So, Rohan, it's over to you. You're probably muted, Rohan. That's all.
Yeah. Am I visible now?
Yes.
Visible.
Yeah. So I will just quickly move on with the case. So this was a 76-year-old female who comes with mid-back pain 2 days ago with an alleged history of trivial fall. She has symptoms of transitional pain and mild pain over the anterior aspect of the left thigh. No bladder bowel symptoms. She has a past history of D12 Kummel's lesion, which was initially managed with vertebroplasty elsewhere. She's a known diabetic and hypertensive. On clinical exam, there was nothing significant except for the fact that there was tenderness over DL junction. This is the MRI. So the surgeon there has gotten this MRI. So my question to all of y'all is at 76, with considering the fact that D2, L2 is still a part of the D10 to L2 junction, how many of you would have aggressively treated this? Or should we have gone with the conventional 85% get healed with conservative therapy? So that is the stir sagittal. There's a T2 sag. There's a coronal stir, and there's the axial. Shailesh sir, we'll start with you.
Now, just a second, Rohan. I am just answering some answers. Sorry, I didn't see you.
Yeah. For me, it's conservative,
So,
Rohan. I
Abhay sir, yeah.
would sit tight and give medications and wait, even though it's a
Wait.
thoracolum.
Yeah. So, does it have to do anything with the morphology? Like we talk a lot about osteoporotic compression fractures, but in reality, there is a certain component of fractures which are burst fractures as well. Would you still go ahead and do the same junctional?
Yeah, for me, if there's posterior tenderness, which is rare, but it is seen, which means that there's a PLC disruption, that for me would be a burst fracture, and just a mere burst fracture would not be a burst fracture in a OVCF.
Okay.
Yeah.
See, expanding that particular answer, whenever there is a kyphotic change, the facets open up. The pain posteriorly is basically more because of the facet opening up and a facet dysarthropy like an arthritic facet. So the T2 image says that it is going to progress. If the kyphosis increases over a period of time and the pain quotient increases, we again need to relook at the morphology and the treatment pattern.
So, sir, 76, comorbid, and you would still wait and watch for this, right?
2 weeks max.
Okay. Shailesh sir, I think you are the one who's left now for this.
Yeah. No, I think maybe I'll initially give a trial of anti-inflammatory and just monitor.
तो डॉक्टर सिद्धार्थ, आप वर्टिब्रोप्लास्टी डे 1 या फिर रुकेंगे?
Never vertebroplasty day 1. even if it has to be cement augmented, I think the ideal candidates are the ones who've at least waited for 10 days. Sometimes the fracture here, pain, the fracture hematoma, it differs on day 1 and day 7 or day 10. There may be something that resolves naturally. I think we might want to wait for at least a week, 10 days.
Also, I am not very happy with the marrow. Maybe I will do some blood workup also in this.
Okay. So, what does your blood workup look like? Does
I
it
normally
have?
do a myeloma profile.
Okay, sir.
And
And do you do the CBCSR CRP as well just to rule out infection because you may have that one
no,
out
it
of.
is by default. Myeloma, metabolic, and CBCSR therapy is
Okay.
very, very important. Of
Okay.
course.
Yeah. So moving ahead, so she underwent vertebroplasty elsewhere. Within a week of her presentation, she did well for 2 days and now has recurrence of symptoms since day 3. Now these symptoms have aggravated over the month, and she still does not have relief. Now she goes back to the primary surgeon, and he again repeats the MRI after 1 month. So now this is the MRI. So, is Unni sir there? If he can take a call on this now, what do you see? Like, is it the same MRI like what we had before, or do we have a newer MRI? I mean, do you see a change, any new changes on this MRI? Or maybe Vishal sir can answer if he's around. Okay, any takers for this one now after 1 month?
cases.
Siddharth.
So, Rohan, do you have an X-ray?
Yeah, so that is exactly my point. So I did not have an X-ray because this is all that the patient has now presented to me 1 month later. But this is the second MRI done after the first procedure.
So see, there is a lot of signal changes now at other levels which were looking worse than the previous level. So
Right.
I have signal changes at 2 and 1 and T12 also. So
Yeah.
although the T12 was supposed to be an old fracture in the first MRI, now there are certain signal changes which lead me to believe something is going on there. Plus, I
Yeah.
want to know whether the guy has cemented the right level. Is there because there's a very dark shadow above also now, whether it's an adjacent fracture or what is the exact morphology of cement, its position, any leakage. So post vertebroplasty, I would always get a plain X-ray at least just to see what is going on. Ideally, maybe some sort of a dynamic film, whether it's a sit to supine is fine, whether it's prone bolster extension is fine. I think all of them try and give you the same idea of what is moving and where is it moving.
Right. So apart from this, in your experience, what could be, if there is any other reason of the patient not improving on whatever you have offered? Like, let's just say this patient had a Kumals, and then you've treated her with vertebroplasty at 6 weeks, and now she's coming back on day 2 or maybe day 3, or having persistent pain for a month. So what all do you look for? Like, how do you
Where
think?
either you go back to the drawing board, make sure, are you missing, are you thinking something is secondary osteoporosis where it's something more sinister. You do have adjacent fractures that happen adjacent to a cemented level because suddenly that elastic tensile yield of the vertebra has changed, and something that is enough to cause adjacent level fractures. So that could be another reason. You want to but rule out any medical cause for this type of multiple fractures. So anytime you have multiple fractures at presentation, I think you have to be more careful and make sure you're not missing anything, and cross your T's and dot your I's. So including your myeloma profile extended to the hemogram metabolic profile and see.
Okay. So that is what we all like. This is the normal algorithm that we all follow. So now she comes to me for evaluation, and what I do is the simple X-ray. So this is what the X-ray looks like. So we have an old vertebroplasty of D12, which is a Kumal, and now we have several vertebroplasties at D11, L1 done from various pedicles. But a simple X-ray would actually highlight that we have actually missed out the primary cause, which is a L2 Kumal's lesion, or an L2 fracture which has now slowly progressed to a Kumal's lesion, and which is clearly seen on an X-ray, which is the supine film versus the sitting film. So
Even
yeah,
the first X-ray which is on the extreme left, I think there was a fracture at L2 to begin with there also.
Yeah.
And that has only progressed because the anterior cortex is ballooned out on that X-ray. I don't know what is the timeline of these X-rays, but
Yeah. So
this
this
could have
X-ray
been a
was,
L2 that was missed or the primary time of vertebroplasty itself.
yeah, so the primary scan was done when she had fallen, and after that, no X-ray was done. The patient was taken up for vertebroplasty straight on the scan. And then, even after that, when she persisted with the pain, the surgeon went ahead and did another scan, eventually to find this out, but there were no X-rays done. And this is where the first speaker who tried to talk about whatever the signal changes look on an MR. So this is where it is very important that what to address. Like even if you see it on a fresh fracture, you will always see that stir signal, and you will just not go on vertebroplasting every level that you see, even if it is an old healed fracture. So this is a very important point I wanted to highlight, that not every fracture, even if it is consecutive, has to be vertebroplasty. But now this patient has now come with this to us, and what I've done is done a simple X-ray, a supine film versus a weight bearing film, and now we can see an L2 burst fracture, which is 2 months old. Shailesh sir, final plan. Now, she has 3 level vertebroplasties higher. They have used the left pedicle at L1 and the right pedicle at D12. I mean D11. Now, how do you go about this? Do you still go for the kyphoplasty at Kalidat sir said, or a vertebroplasty like Siddharth said, or go like a full Monty and fix everything? How do you
How
go
bad
about
is
this?
the pain?
Sorry, the pain
How
is
bad
very
is the
severe. She has been bedridden since day 2 of her first procedure, and it's almost been 2 months now.
No, but at L2 now, cement augmentation is not on the table because it's now DGOU 4 or 5. There's complete loss of the vertebral frame. So
Yeah,
cement will not hold there. Now it's
Okay.
time for the big bosses to come. You call
yeah. I
Hadgaonkars
think
and
we should. Yeah,
Krishnans to come
yeah.
in now.
We should consider fixing, and we should use. We have published this where we use the vertebral cement, augmented cement for putting the screw. We have published it 10 years back. So
Yeah.
this is what we should do. We should put screws above, below, and use that levels, all levels where we can, use this
Okay,
drills
sir.
and
So,
put the
so one
screws.
question, one quick question. Where would you put your anchors? Final, like where all?
Anchors.
I mean, where all will you put your screws?
Yeah, all levels.
All levels, sir.
And
But there is
above, maybe.
vertebroplasty at
They
pedicles
are the
on
best
contralateral
levels.
side.
Vertebroplasty levels are the best levels because you can get a very strong hold.
Sir,
That's
but
what
that
we
pedicle has been already used for the cement being pushed. So do you think the new screw will go through that?
yeah. Why not? That's not a problem.
See, a
And
That's
it's
simple
occupied
like
a.
technique.
I'm going to
Yes,
show
sir.
you the case where we use the drilling technique in the previously operated vertebral levels where you can
Okay.
Yeah.
drill and put a very strong screw. That's the
Okay.
best.
Kalidat, sir, you were saying something.
So the same thing, I'm just elaborating on what Shailesh said, that you use a 2.5 drill and
Okay.
you serially use a dilated drill and use a 4.5 tap on
Okay.
in the drill hole and use this tap screw to either use a 5.5 or then you can serially increase it to a 6.5 screw. Number one, you can also increase and change the trajectory of the screws in the same particular to get a better anchorage and hold. Now
Okay.
that these are already screwed and you're going to do a stabilization, you can perforate the anterior cortex and the discal spaces also to get a 3-point stabilization. So all this, including
Yeah.
using of hydroxyptide screws or sublaminar wirings and all that can be added onto your stabilization procedures.
Nene, sir, same plan, or do you go with sublaminar wires only
Yeah,
now?
maybe
How?
because she looks like completely shot out. No, I may just finish it off with a sublaminar wire hard shell. Though
Okay.
I'm completely comfortable with putting screws in the cemented vertebrae like your other two colleagues.
Okay. Then do we go for that sagittal and coronal alignment like Unni sir showed before, or do we just now stick to pain management?
Yeah, just fixation.
Okay. Okay. So I think most of the points were discussed. So I will just move on to what I have done. This is what I did. I went in and I did a fenestrated screw at L2. So I restored that height. And wherever they had vertebroplasty, I went to the contralateral pedicle and I put the screws there and I went a level below. because there was enough cement higher, I thought that was indirectly a soft landing for me. So I know that those levels are not going to collapse. And therefore, I only used the contralateral pedicle and got away with this. Hopefully, this should stay. And sir, any comments?
I think in situation you really did it well because there is a very strong hold. You can see that at least here, and the cement is coming close to the screw. So your hold must be very good in both the upper levels. And
Yes.
once you get that, you manage that L2 very, very well. So you have two anchors below. So I think his patient should do well.
Yeah, and like you all said, I had directed the proximal most screw inferiorly because that strut of cement was very strong. So either you drill it out or you just find an alternative trajectory. So
Yeah.
I went slightly inferior. Yeah, so that's as simple as my case was,
You did a
and I
very, very
thank you all.
minimalistic job. Probably a lot of people would have gone two levels above the upper cemented level, and they would have done a long, long
Sir,
construction.
yes, sir. So the only explanation to this was because there was already cement higher, they were
Yeah,
already acting as a stronger,
soft
like a soft
landing was
landing kind of
yeah,
a thing for
yeah,
me.
yeah.
So I did not go higher. Yeah. Sir, Kalidat sir, Nene sir, any comments, please?
No, lots of learning points, I think, for everyone. So thank you. That was superb.
Thank you, sir.
Very
And
nice, very nicely done. And it just needs a follow-up to see how it holds on in the next few years. And I think this can be a good case for further discussions.
Thank you, sir. Thank you.
Shailesh, you're going to bring up the rear and then close the seminar for us. So the last presentation, which also has some learning points, is a
I'll
case.
just quickly go through. I have some rapid fire because I'm covering up the different techniques for fixation, and I'll just scroll through very fast in this. These are the very commonly seen scenarios: 78-year-old female, adjacent segment, porotic, and a very, very challenging scenario. We use navigation. You can use 2D also, not a problem. But we use this sat nav, and we have sent our paper for publication for all this adjacent segment where we have a very strong, almost 1.5 to 2 times stronger hold than any other implantation. And this is very, we have done around a large number of series with these kind of cases. And this is one way. Now, if there is a patient with porotic fracture and persistent pain, not better, I normally prefer a long screw, bicortical screw, and anterior cortical hold is very, very important. If you see here, all the screws are long and they are holding the anterior cortex. Dual core screws at junctional level, they really work very well. So that's one very, very important practice which we do for a long time now. Again, this kind of images where we do feel that the bone quality is not so good, I prefer to use cement augmented screws, and really they work very, very well in these scenarios. Now we have seen the proximal junction. Now this is a 78-year-old patient, and this was his X-ray stenosis. And he comes back. He went home in 3 days, decompressed, stabilized. He comes back in 3 days with back and leg pain, and at 1 month with bladder and bowel involvement. He had a fall, and he went to a urologist, and various things we were in mind. He came to us at 4 weeks. We got his MRI done, and X-ray shows something very, very uncommon, and we were really, really worried. What is this happening? If you see this, something which is never seen. We are doing so many surgeries for a very long time, but this was very, very unusual type of a fracture, and we thought, what should be the reason? And then we did a CT where we can see a flake which is there in the canal, something which is broken and gone behind, causing compression, but the MR is not showing anything. That's something which was very, very unlikely, and we had no option. We explained that at 6 weeks he was with completely. He did everything with the urologist, and he said the urologist said this is not from our side. Then we explained that we need to decompress and see whatever is happening. We decompressed. We planned for again a satellite rod, which we normally do, an augmented screw. We use navigation, and we decompress it completely, and very strong construct which we could do it at that level. We could get that flake out, and that fracture, which was a distal junctional fracture with like osteotomy, which really healed well. again was mobilized in 3 days, and now it is nearly 1.5, 2 years. He's completely asymptomatic, ball bladder better, and he's very, very happy. We were lucky. Again, such cases comes to us operated elsewhere for a small fracture, thoracolumbar. It's what normally they say it's a day one failure, that this is not a right thing, but probably it's in the learning that everyone can do such mistake. When we received this patient, we had no option. Patient was in a lot of pain. Then we planned for sparing the level and going above and below. And again, these are long 5, 7 year, 8 year follow-up. I use 90% of the patients of mine are dual core screws, long screws. I don't like short screws, and that's my practice for a really long time before activation also. We use that. Again, this was a patient where we have sublaminar. Yeah, 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 we need sound, yeah. And this is again a patient, persistent pain, very skinny lady comes to us with this pain, and she was with bad pain. We planned for a sublaminar wire, and now it is 8 year follow-up. She's really doing well. We published this also. This is a Angst pond where we do see some fracture at L4. They are the challenging situations where these patients are in trouble. I'm going to show the case again. This is a 49-year-old, severe back pain, and he was with adrenal tumor and surgery for that, diabetes, insulin, hypertension, all these things. And there were 5 level which were with the cement augmentation, vertebroplasty was done. This is a patient from abroad, and he was in bad pain, 8 to 9 on 10 persistent. He comes to us, and there was severe kyphosis, and we planned for giving him medical management. He said, "Doctor, it's enough. I'm taking for it is almost 1.5, 2 years. I'm not settling." Sitting was painful, walking was painful, and there was severe kyphosis. Again, this we planned for a long deformity correction. We explained it's a multidisciplinary approach. We need to plan. We did everything, and we use this cement as an anchor for fixing. We published this case, and that gives you a very, very strong hold. This again a 10 year back we did this case. This patient with 5 year follow-up was really doing very, very good. And that time we did lumbopelvic fixation. He was absolutely fine for 5 year, and then we lost for the follow-up. This was his clinical picture. This was the case which came in between, and this is a 68-year-old lady jerk while walking, and there was an Angst pond, there's a fracture, and these are very, very notorious and bad fracture, very, very painful. We planned for a small surgery because we wanted to spare levels and lumbar spine. Despite of this, we did the kyphoplasty and minimally invasive fixation. Again, a 2 year follow-up. This patient is doing absolutely fine. It's completely fused at this follow-up. This is a case where there is a thoracolumbar fracture, persistent, and some amount of retropulsion. We don't prefer to use cement augmentation when there is a retropulsion. We don't prefer this. Here we did balloon kyphoplasty and cement stenting. We have a large series of stenting in the spine, and under navigation, we were the first ones to publish in the world. And these are the cases where we did the cement augmentation with stenting, and this is a vertebral body cement and stenting which we used. Various cases and various different things, but we need to understand where this again a case where there is a fracture below, there is a fracture with a retropulsion, where we stopped at a right level. We did our kyphoplasty. I prefer normally doing kyphoplasty in most of my cases, and this gives you a very strong hold. Sometimes if you're not getting a good hold, you use the cement augmentation at the top and lower level, and really you can get a very, very good hold. And you need to monitor them. You need to explain them well. Again, preventing falls is important. Various different techniques can be done for preventing this, and for osteoporosis. It's a disease. We need to have a very, very good medical management as well. Thank you for patient listening. Thank you. I can go on for many.
I think all the cases covered mostly the whole spectrum of what we discussed until now. The fact that we've gone on to 10:50 means that this has been a super enriching seminar, and I learned a lot. Shailesh, you want to wind up?
Yeah, just Jaspal will quickly rapid fire the review of literature, and we are done. Jaspal, Dr. Jaspal Pardeshi, the ASSI fellow.
Yeah. So I'd like to thank ASSI and Dr. Shailesh Hadgaonkar for giving me this opportunity. So I'll just quickly wind up with what is the review of literature and current trends in the osteoporotic fracture management. So most of it has been covered already. So this is paper from 2025 Spine Journal giving guidelines. So this is for the conservative management. How does the conservative management for the osteoporotic vertebral fracture goes on? Initially, start with stepwise approach for the analgesics multimodal as previously discussed by Dr. Kundani. Early mobilization, TLSO bracing for short duration, structured physiotherapy, osteoporosis pharmacotherapy. So this is the core component of the conservative management that is to be given. We look for the response 2 to 6 weeks. If the pain improves, we will continue the conservative management. If the patient persists with pain on follow-up at 2 to 6 weeks, then we consider augmentation. So, depending on the augmentation, what is the optimal management for osteoporotic vertebral compression fractures? This was a paper from 2025 Journal of Orthopedic Surgery. So it discussed the vertebroplasty versus kyphoplasty. So as we have discussed quite clearly in the debate, we all know what are the pros and cons of each method, and it is completely surgeon-specific method, and both of them have their specific reasons to be done. So height restoration, which is seen better in the kyphoplasty, pain relief is equal on the both sides. Cement leakage little higher in the vertebroplasty, and relative cost is kyphoplasty is higher. So more or less, both of them have similar results, and it is completely surgeon specific. So what to do? So as we all have discussed next, that is the osteoporotic pharmacotherapy. It is utmost important at whatever management, surgical management we give to this patient. The pharmacotherapy has to be started because it forms the essence of the treatment. So, as the Dr. Vishal Kundani sir has discussed, this is the drug hierarchy that is to be started. Teriparatide, that is the anabolic. It is the first line of treatment that is to be started, followed by romosozumab, denosumab, bisphosphonate, depending on the profile of the patient. So, anabolic agents build new bone, whereas anti-resorptive uh, agents are those that slows down the bone loss. So, sequencing anabolic bone first, then consolidating with anti-resorptive maximizes the BMD gain. So, this is the current trend that we have to treat not just the fracture but also the medical disease that comes along with the osteoporosis. So next is a current debate for the treatment of osteoporosis, that is a long segment versus short segment. So there has been enough paper suggesting higher feasibility of the longer segment because in osteoporotic fractures there are already altered biomechanics and the hold of the screws are not good. So having a long segment fixation definitely will give better anchorage in the osteoporotic vertebral fractures. So this shows the comparison of the long segment fixation versus the short segment fixation. So even though the blood loss is little higher in the long segment, but you know the implant failure rates are quite lower, revision rates are quite lower, and clinical scores are comparable on both sides. Longer segment will provide superior mechanical stability in severe osteoporotic fractures. So next comes up the short segment fixation with kyphoplasty. So here now recent literature has come up with short segment with along with cement augmentation. So motion, what are the advantages? That the motion preservation is there, better anterior column support. It reduces the screw loosening and comparable pain outcomes. So modern short segment constructs are increasingly successful when combined with vertebral augmentation. Thus, we can spare the multiple levels and can restore the regain the mobility of the patient. So, in osteoporotic vertebral fractures, as we all know, we don't have multiple attempts to put on the screw, and the fracture morphology can be difficult. So, we have a paper published at our institute by Dr. Shailesh Hadgaonkar showing the accuracy of OARM in guiding the screw in the precious pedicle. So, our paper had shown 99.5% of accuracy was studied with only one pedicle screw bridge. So conclusion was that OARM navigation is most accurate technique to date and should be method of choice in osteoporotic spine fracture because multiple attempts in the osteoporotic spine fractures can cause breakage of the pedicle and loosening of the implant. So this is how we do it. Since the OARM we can be very minimally invasive. We don't have to cut open all the level, and we can preserve the midline. And also, since these are highly comorbid patients, so with the minimal comorbidities, we can do the surgery. So, what is the final line of management? Clinical diagnosis MRI confirms acute fracture. If patient has a neurodeficit, straightforward, we go for instrumented surgery. If there is no neurodispute, then conservative treatment, pain persists, then we can go for vertebral augmentation or posterior stabilization. So what are controversies and future directions? Cement augmented pedicle screws that are already in treatment. Expandable pedicle screws under trials. Cortical bone trajectory sometimes used when we have to do satellite nav technique as we usually do here. Navigation and robotics under currently in use for osteoporotic spine. Patient specific fixation strategy and AI assisted fracture predictions. So this is a take home message. Conservative treatment first for the neurological intact patient. Augmentation in carefully selected patient with persistent pain. Long segment fixation remains the gold standard. Modern short segment with augmentation is promising alternative. Bone health optimization is mandatory. Future lies in personalized morphology driven fixation. Thank you.
Thank you, Dr. Pardeshi. You covered up the literature in very short time. I think we try to cover everything possible for benefit of all our audience and also the senior faculty. Discussions really will be fruitful for even if you learn one single point from everyone's presentation. So thank you once again. I wish to continue the webinar in the next month, second Tuesday. Most likely will be on infection, but looking forward and I thank all the esteemed faculty for their wonderful support. Dr. Nene and my colleagues, thank you. Looking forward seeing you once again. Thank you all from all over. Thank you.
Thank you. Good night.
Good night. Good day.